This is the ENT part of this game changing session, and in this around 15 questions will be asked in your main examination, and most of the questions, which will be around 10 questions for sure, you will get from this session. Okay, from this PDF itself you will get minimum number of questions, it is 10, and maximum you can get all the questions also from this PDF. Okay, and try to analyze this all the concepts and try to solve questions by applying it, because you read, you forget, there is no meaning, but you should read, you should solve questions, then only you will be able to remember in a long run. So your motto should be read now, revise it, and do questions. We'll move ahead. First we'll see the first condition, which is known as malignant otitis externa. What is this malignant otitis externa? We know otitis externa means it is the infection of this external layer, but usually they will spare, like they will spare asking this, but they will ask this condition, which is known as malignant otitis externa. It is not a malignancy condition, it is malignantly means it is for chronic condition. It is a chronic conditions or chronic inflammation of this external layer. And if you see this here, you will be able to see that is the inflammation, and in this inflammation and infection, you will be able to see there is this chronic ear discharge, and along with this, they will tell the proper history of elderly diabetic patients. These are diabetic patients who is presenting with features of earache and blood-stained ear discharge. Earache, blood-stained ear discharge, and an examination. And once you do an examination with an otoscope, you pull the hair out, okay, and you just kept the otoscope. And once you kept the otoscope, you will be able to see there is this formation of granuloma. So here there will be the presence of granuloma formations will be seen in the case of malignant otitis externa. Yeah, granuloma formation. And we know around the middle layer the patient will be coming, and in some cases this otitis externa can extend into this middle layer, and it can cause this facial nerve involvement and facial nerve palsy as well. Okay, so for treatment of these conditions, what we will do, we'll give this third generation cephalosporins. We'll give this third generation cephalosporins, and the main catch point is that there is a diabetic female who is presenting with this chronic ear discharge. On examinations, you will be able to see there is a presence of this kind of granuloma formations. There will be presence of this kind of granuloma formations. So this is typically suggestive of a condition which is known as malignant otitis externa. Malignant otitis externa. Yeah. Fine. And next conditions, they will classically describe in the history. There is a female. Mostly they will describe it is a pregnant female who is having the features of bilateral conductive hearing loss. So pregnant female having a features of bilateral conductive hearing loss, which was progressive in nature. And on otoscopy, you will be able to see this type of pinkish or mass. Okay, this type of pinkish mass. Okay, so there will be this young female who is sometimes it will be pregnant. Okay, and with this bilateral gradually progressive conductive hearing loss, and they will become, and on otoscopy examinations you will be able to see this type of pinkish mass behind this tympanic membrane, and this pink, it is what it is known as a flamingo pink behind this tympanic membrane. It is known as what? It is known as Schwartz sign. It is known as what? It is known as which sign? It is known as Schwartz sign. And in these conditions, you know, in this condition, the patient will be having a typical complaint that the patient or the female can hear more in the noisy environment. So the patient will tell like, sir, in normally I am having some hearing loss, whereas if it is very loud environment, she can able to hear much better. So she hears better in noisy environment. और उसको बोलेंगे 𝗏𝗏𝗃𝗃 विलिसे. Yeah, 𝗏𝗏𝗃𝗃 विलिसे. So इतना याद रखो. If there is a diabetic female who is presenting with chronic ear discharge, और जैसे आप देख रहे हो, when you examination, you will able to see this there is a presence of granuloma, then you will diagnose this as malignant otitis externa. Agar if there is a pregnant female who is presenting with progressive conductive hearing loss, and on evaluation you will be able to see this flamingo pink mass behind this tympanic membrane, okay, which is known as Schwartz sign, and on asking more history, she tells a normal quiet environment she is having this hearing loss, whereas if there is any noisy environment, जैसे noise होता है, then she can able to hear better. So this is a classical history of this otosclerosis. Yeah, बढ़िया. Okay, and in the case of otosclerosis हमें पता है there is this PTA. In the case of pure tone audiometry, you will be able to see there is a drop at 2000 Hz in the bone conduction curve. In the bone conduction curve, there will be a drop at the level of 2000 heads. Drop at the level of 2000 heads. What is the name of this notch? What is the name of the notch? You will call it as, yeah, there is a dip at 2000 heads. It is known as which notch? Which is known as what? 𝗏𝗏 notch. It is known as what? 𝗏𝗏 notch. It is known as 𝗏𝗏 notch. ठीक है, तो इतना याद रखो. It is known as 𝗏𝗏 notch. अगर आप जैसे आप देख रहे हो, आपका पता चल गया, there is a presence of this flamingo pink mass behind this tympanic membrane, then you should think, yeah, it is an active disease. In the case of active disease of this otosclerosis, तब हम एक ड्रग दे सकते हैं, उसका नाम है सोडियम फ्लोराइड. Then we can give a drug which is known as what? Which is known as sodium fluoride. So if there is any presence of this active disease, तब हम सोडियम फ्लोराइड दे सकते हैं. ठीक है, इतना याद रखो. Then, but if it is a chronic progressive disease, if it is not an active one, फिर उसके बाद हम दो चीज कर सकते हैं, स्टेपिडोटमी और स्टेपिडेक्टमी, दोनों कर सकते हैं. But mostly we'll prefer this स्टेपिडोटमी. Will do स्टेपिडोटमी. इतना याद रखो. Will do so स्टेपिडोटमी. Yeah. This sodium fluoride, if it is vacutainer, it will be in a gray color vacutainer which is used for the blood collection. So yeah, nice, good correlation. Fine. फिर उसके बाद आगे बढ़ते. There is a child, like now there is a child who is presenting with features of this adenoid hypertrophy. Okay, there is this features of this overcrowding of this teeth, and there is this high arched palate, and complaints of cough, fever, and he also complains there is a presence of some degree of hearing loss. Some degree of hearing loss. तब आपको पता चलता है, yeah, there is something fishy in this child. Then you pick up the otoscope, आपने गौर से देखा, then you will able to see there is a presence of this air fluid level behind the tympanic membrane. Okay, जैसे bubbles देख रहे हो ना. So if you are able to see this air bubbles inside this tympanic membrane, this will be suggestive of a condition which is known as serous otitis media. Serous otitis media, which is also known as, yeah, multiple air bubbles, which is known as what? Serous otitis media, which is also known as glue or secretory otitis media. Okay, glue also known as secretory otitis media. और हमें पता है this secretory otitis media, it is a sterile. Okay, because of this eustachian tubal block, there will be these secretions which will be collected into the middle ear, which is causing this serous otitis media, and it will be sticky like a glue. So it will be a glue, also known as glue ear. Okay, and if it is seen in children, it is mostly due to this adenoid hypertrophy. अगर आपको glue ear मिल रहा है, then you will tell, yeah, don't worry, mostly सही हो जाएगा. तो initially you should reassure and do conservative management. अगर if it is not managed for more than 6 months, then you should do what? You should do this one, which is known as what? You should do grommet insertion. Okay, you should do grommet insertion. Okay, इतना याद रखो. If it is more than 6 months, if it is not managed conservatively, फिर उसके बाद आप grommet insertions करोगे. ठीक है? Then we know it is happening because of this adenoid hypertrophy. So in a case of children, if it is happening because of adenoid hypertrophy, फिर तब हम दो चीज करेंगे. एक adenoidectomy करेंगे, एक adenoidectomy करेंगे. अगर जैसे adenoidectomy हो गया, then the glue ear will regress. If it doesn't regress, फिर उसके बाद will do grommet insertion. Then in a case of adenoid hypertrophy, will do adenoidectomy along with grommet insertion. तो इतना याद रखना. Whereas if you use elderly patients, and he is mostly presenting with features of unilateral hearing loss, along with some cervical lymphadenopathy and bleeding nasal mass. Okay, all of this suggestive of nasopharyngeal carcinoma. So in the case of nasopharyngeal carcinoma, it will cause unilateral serous otitis media. Okay, it will cause unilateral serous otitis media. इतना याद रखो. Fine? Yeah. Then in a case of this nasopharyngeal carcinoma, it is due to this Epstein-Barr virus. And we know here also we need to treat the cause. We need to treat the cause. Fine. We need to treat the cause, and if it doesn't resolve, then we need to do myringotomy along with this grommet insertion. Or shall I ask you a question? In the case of tympanogram, what is the name of the curve this serous otitis media will produce? Will this produce which type of graph? In the case of serous otitis media, बताओ, it produces flat. It produces this flat type of graph, which is what? Which is this B type of graph. It produces this B. No, it's not C. It is B type of graph. Okay. Remember B for barra hua pani. Okay, means it is filled water. Okay, it is filled water which is present. That's why it is known as serous otitis media. Next, if this condition, if it is getting infected, okay, then it will lead to two conditions, which is known as what? Serous otitis media. Okay, it can convert into two conditions, which is known as what? Acute suppurative. Acute suppurative means there is this pus formation. Acute suppurative otitis media. Okay, acute suppurative otitis media. So in the case of acute suppurative otitis media, there will be formation of this pus. Okay, pus, and will produce a type of appearance which is known as cartwheel appearance. Cartwheel appearance. Okay, cartwheel appearance करेगा. Then if this ASOM regress, ठीक है बढ़िया, कोई दिक्कत नहीं है, सही हो गया. लेकिन in some cases there will be this ASOM which is being progressed to this next condition which is known as chronic suppurative otitis media. Means chronic suppurative otitis media means chronically the patient is experiencing this discharge. Okay, and this chronic suppurative otitis media, how will the discharge will be coming? It will be coming via either two route. Means there will be like mostly there will be small opening or small perforation in the tympanic membrane which is mostly aligned at the center, and the pus is coming out. Whereas in some cases there will be a large opening and large amount of pus will be coming out, or scant or blood tinged pus will be coming out. So based on it, we'll differentiate into different types. If you see this type of central perforation, we'll call them as 𝗃𝗃𝘁𝗀𝗀𝗀. Now we'll call them as 𝗃𝗵𝗶𝗀𝗀𝗃 𝗃𝗁𝗀𝗀. It is known as 𝗃𝗵𝗶𝗀𝗃 chronic suppurative otitis media. Okay, it is known as 𝗃𝗵𝗶𝗀𝗃 suppurative otitis media. Okay, there is this presence of this permanent central perforation and this first stanza of this tympanic membrane. Okay, and here the discharge will be more. Here the discharge ज़्यादा रहेगा, लेकिन but there will be no foul smells. There will be no foul smell and there will be no blood stain. So there will be a more discharge with no blood and no foul smelling. It will be without any smell. Just remember. And here the hearing loss will be conductive because there is a perforation. It will cause a conductive hearing loss. फिर उसके बाद आगे बढ़ते हैं. Then in some cases, if you see, the perforation can reach up to the margins. This is known as marginal type, which is also known as aticoantral. It is known as aticoantral type of 𝗃𝗁𝗀𝗀𝗃. It is known as aticoantral type of 𝗃𝗁𝗀𝗃. Whereas in the case of aticoantral type of 𝗃𝗁𝗀𝗃, remember, there will be small discharge. Okay, there will be opening is large, but there will be small or scanty discharge, which will be foul smelling and blood tinge. Okay, opposite of this 𝗃𝗏𝗃𝗃. So it will be what? It will be foul smelling and blood tinged. Okay, it will be foul smelling and blood tinged. Blood stain present along with this foul smelling. In some cases, this will heal and it will retain some of this epithelial tissues, normal epithelial tissues from the EAC to into this middle ear. So this can lead to this formation of thing which is known as cholesteatoma. Cholesteatoma is nothing but a presence of a skin in the middle ear cleft. Okay, presence of the skin which is this epithelial cells into this middle ear cleft. So it is known as cholesteatoma. In the condition, in a type of cholesteatoma, there is this intact tympanic membrane. If the tympanic membrane is intact in a case of cholesteatoma, then it will be which type of cholesteatoma? It will be a congenital cholesteatoma. It is the congenital cholesteatoma. It is the congenital cholesteatoma. So remember, if the cholesteatoma is present, but it is present along with this intact tympanic membrane, फिर आपको याद रखना है, it is a congenital type of tympanic membrane. Okay. Next, this aticoantral type of 𝗃𝗁𝗀𝗃 can also be complicated with one more syndrome which is known as Grany-Dingo syndrome. Like it can involve this petrous part of this temporal bone and it can lead to this following complications. So क्या कर सकता है? So if you see here, obviously it is a complication of the 𝗃𝗁𝗃. It will produce this ear discharge. Ear discharge रहेगा. फिर उसके बाद there will be a presence of this retroorbital pain. There will be the presence of this retroorbital pain. So आंख के पीछे there will be दर्द रहेगा because of the involvement of this fifth nerve. Because this petrous part it will be in relation to the fifth and the sixth nerve. Then there will be diplopia. हमें पता है this extraocular muscle LR6 and SO4. So the lateral rectus it will be supplied by the sixth nerve. Okay. So because of the sixth nerve involvement, there will be presence of this diplopia. So remember, it is the GERD. GE. Okay. This Grany-Dingo syndrome, it is the ear discharge, R for retroorbital pain and D for diplopia. Remember it as GERD. Okay. Remember, it is the retroorbital pain. Then followed by this, there will be a diplopia. So itna yaad rakho. Then about this next condition, the patient now will be presenting with features of pulsatile tinnitus. There will be features of pulsatile tinnitus and sometimes there will be complicated by this bleeding from the ear. Okay, bleeding from the ear. Pulsatile tinnitus, bleeding from the ear. Both of them, they are suggestive of a condition which is known as glomus jugulare. Okay, and we know this glomus jugulare, it is a non-capsulated tumor. It is mostly locally invasive, like it will invade this part of this middle layer, especially on this floor of the middle layer. Okay, and it is a highly vascular tumor. Okay, and the female means mostly it occurs in young females with the features of this pulsatile tinnitus and bleeding ear mass. Okay, and if it is not bleeding, then once you see with your otoscope, you will be able to see there is a presence of this pulsating red side or this mass which is arising from the floor. So it is known as what? It is known as rising sign. Okay, जैसे नीचे से ऊपर आ रहा, so it is known as what? It is known as rising sun sign. It is known as rising sun sign. Okay, then there is one more sign, like if you put pressure by an instrument which is known as 𝗚𝗚𝗚, then this blood, it will blanch. So this blanching is named as brown sign. Okay, the blanching, it is known as brown sign. तो इसको diagnose करने के लिए क्या आप biopsy करोगे? What will be answer? Will you do biopsy to diagnose this glomus jugulare? What will be answer? No. A big no. If you see, in the case of glomus jugulare, it is a vascular tumor. So here you won't do biopsy. So biopsy is contraindicated in the case of glomus jugulare. Okay, to removal, we'll do embolize and we'll do surgically remove it. Okay, we'll do surgically remove it. That's it about this glomus jugulare. Next, about this BPPV. This BPPV, the patient usually tell like there is a presence of this vertigo. There is a presence of this vertigo, and this vertigo, this BPPV vertigo, it is the most common cause for this peripheral vertigo, and it happens because you know this crusted maculae where there will be presence of these small stones, they are known as otoconia. This otoconia will be displaced to this semicircular canal, and it will cause irritation and it will cause vertigo during the positional change. Okay, so their chief complaints will be change of position will causing this vertigo. Change of the position will causing this vertigo. Yeah, it will just remain for a few seconds. It will just remain for this few seconds. And to diagnose this vertigo, remember there are two tests we'll use here. Means two things we'll use here, are two manuals. To diagnose this, remember D for D. To diagnose, we'll use 𝗵𝗵𝗴𝗿 maneuver. It is known as D for D. To diagnose, we'll use 𝗵𝗵𝗴𝗿 maneuver. Okay, and D for D, it has how many moments? It has two moments. Okay, एक और दो, बस. अगर उनको vertigo हो रहा है तो हम बोलेंगे या इनको BPPV है. ठीक है, then to treatment this, we need to reposition. ठीक है, this otoconia, they will come and settle in here. Okay, तो गलत जगह आगे रुक गए, so we need to reposition them. So reposition करने के लिए we'll use a maneuver which is known as 5-step maneuver, which is known as what? Which is known as E. It is a ABCDE. It is the fifth alphabet. So it is what? It is the 𝗵𝗚𝗚 maneuver. It is the 𝗵𝗚𝗚 maneuver. So 𝗵𝗚𝗚 maneuver, it is used for the treatment of this benign paroxysmal positional vertigo. Okay, बढ़िया. बढ़िया Dr. Ashley, बढ़िया Dr. Dr.G. Next, we'll move on to one more condition, which is known as what? Which is known as Meniere's disease. Meniere's disease is nothing but it is just hydrocephalus or more water or glaucoma of this inner ear. So there is थोड़ा बहुत ज़्यादा पानी भर गया. There is more water into this middle ear, especially the scala media part. Okay, so इसमें we know this endolymph, it will be produced. It will be mainly in the scala media part. It will be produced by this stria vascularis. Either it will produce more or what it will do, it will absorb less. So दोनों type पे क्या होगा? There will be increased fluid or increased endolymph. So because of this increased endolymph, the ear will swell. Take it, the ear will swell. It is known as endolymphatic hydrops. Okay, it is known as what? It is known as endolymphatic hydrop. Yeah. Here the vertigo will be usually more than this part. Which one? This BPPV part. Okay. It is usually, this is a type of unilateral and will be having episodic in nature. It will be unilateral and it will be episodic in nature. Kaise? For example, it will be having this peculiar features. There will be initially there will be this tinnitus, ringing of the ears. Followed by this, the patient will be having vertigo. Followed by this, the patient will be having vertigo, and it will be relieved by this hearing loss. Okay, and it will be relieved by this hearing loss. So remember, it is tinnitus, vertigo, and hearing loss. Tinnitus, vertigo, and hearing loss. Here you will see few phenomena. Okay, few phenomena. Recruitment phenomena means here the patient hears loud sounds as more loud. Okay, he will tell कैसे हो. He will tell how are you. The patient won't listen. He will tell how are you. Then he will tell how are you. then when you shout, it feels like the patient, means you are shouting at the patient. So while shouting, actually the patient feels it is more shouting. So the patient feels that the loud is perceived as more loud. So it is known as what? It is known as recruitment phenomena. Yeah. The patient also, good Dr. Shanwas, the patient also will get this vertigo episodes when they exposed to this more sound environments, like where there is this boom speakers are there, where they may predispose this vertigo event. Okay, and there's this phenomena which is known as 𝗃𝗃 phenomena. Okay, and hearing this loud sound, this vertigo occurs, which is known as 𝗃𝗃 phenomena. And here there will be two things. They will hear a same sound in a two frequency, that is known as 𝗃𝗃. It is known as 𝗃𝗃. So here in a case of Meniere's disease, you will see this 𝗃𝗃. Okay, तो याद रखना Meniere's disease में हम 𝗃𝗃 देखेंगे. ठीक है, here there will be Meniere's में क्या क्या लिखा होगा? There will be unilateral disease, there will be a tinnitus, vertigo followed by the hearing loss. ठीक है, whereas in a case of otosclerosis बोलेंगे progressive hearing loss. ठीक है, progressive hearing loss and hearing better in the noisy environment. Hearing better in the noisy environment. ठीक है, BPPV में plus vertigo which is associated with the movement of the head. BPPV में vertigo which is associated with the movement of the head. तो ये सारे चीज आपको क्वेश्चन से उठाना है. Means you need to see this pointers because क्वेश्चन से be written this much long. तो आप एक एक करके पढ़ते रहोगे. A is, was, he, she, like that. You won't able to get them and grasp them in seconds. तो आपको ये कीवर्ड्स पता होनी चाहिए. फॉर एग्जांपल अगर आपको मेनिस डिसीज के बारे में पूछ रहे हैं, इफ दे आर आस्किंग अबाउट मेनिस डिसीज, यू शुड सी दिस वीडियो phenomena mentioned, like there is tinnitus, vertigo followed by this hearing loss, and there is a mentioning of this 𝗃𝗃. So all of this if you find, then you will be able to see it is the Meniere's disease. It is the Meniere's disease. Okay, bas okay. Meniere's disease is the glaucoma. Right. Then we'll move on to this some PTA findings. We'll move on to this PTA findings. Right. This PTA findings, if you see, this is how this normal audiograms looks like. This is how this normal audiogram or normal hearing loss looks like. Whereas if you're able to see, there is a gap between this bone conduction and here ear conduction. If you're able to see this AB gap present, so it is what it is. Typically, it is the conductive hearing loss. It is the conductive hearing loss. See, it is the 50 decibel. Here 50 decibel loss is there. So there is a gap between this bone conduction and air conduction. So it is what it is this. It is the conductive hearing loss patients. Good guys. Then I will show you this mixed note. Fine. Then if you are able to see here this bone conduction is decreased, air conduction also decreased, and you also able to see there is a gap. So air conduction decreased, bone conduction also decreased, and there is a gap present. This is a type of mixed graph. But whereas if you are able to see both bone conduction and air conduction, both of them they are dropping. So it is the sensory neural hearing loss. And if you have a sensory neural hearing loss having a dip at 4000 Hz, it is seen in a case of which type of sensory neural hearing loss, guys? What's the type A? It is seen in a case of which type? At which condition? Good. It is seen in a case of noise-induced hearing loss. It is seen in a case of noise-induced hearing loss. Fine. Then we'll see this tympanometric findings. Okay, at tympanogram findings. If you see this next graph, if you're able to see, this is how this tympanogram looks. Okay. Here, what we'll see the mobility of the tympanic membrane. So, based on this mobility of the tympanic membrane, we'll tell what is the problem with the tympanic membrane. See, the normal one, it is what it is the normal one, it is the A type of graph. This is the normal one. Okay, this is the normal one. Okay, this is the normal one. This normal one, I have this A type of graph. Okay, A type of graph. Whereas, in the case of, as I told you, if you see this type of flat graph, if you see this type of flat graph, it is seen in a case of, if you see this type of flat graph, it will be seen in a case of, कौन से में देखेंगे? B types, flat, B type will be seen in a case of serous otitis media. ठीक है, अगर आप ज़्यादा पानी पी लेते हैं, अगर ज़्यादा दारू पी लेते हैं, तो फ्लैट हो जाते हैं. Remember, it is the serous otitis media, which is having this पानी, which is having this दारू और alcohol, then it becomes flat. ठीक है, तो इसी वजह से फ्लैट हो गया. Then if you see this another type of graph, if you are able to see this type of, if you are able to see this type of same A type of graph, लेकिन ये बहुत छोटा है, small graph. A type of graph will be seen in a case of otosclerosis. Otosclerosis will be seen in a case of otosclerosis. ठीक है, फिर उसके बाद आगे बढ़ते हैं. Then if you see this graph which is not meeting like your x and u, okay, if it is not meeting, okay, they are not tend to meet each other in future. So if they are not meeting, okay, not meeting, so it is what it is, this AD, which is what, which is this dislocation. It is due to this ossicular dislocation. It is due to this ossicular dislocation. Yeah, they are discontinued. That's why it is your x, right? So it is what it is, this ossicular dislocation. Ossicular dislocation. Okay. Then, if you are able to see this type of same type of A graph, but it is located somewhat before it. So it is what it is, type C graph. It is the type C one, and this type C type of graph will be type C1 will be seen in a case of where कहाँ देखेंगे हम, type C will be seen in a case of eustachian tubal obstruction. Eustachian tubal obstruction. Okay, type C. Fine. So these are the tympanometric findings you need to remember. Fine. Next, we'll move on to this facial nerve anatomy and injuries. Initially, we know the facial nerve will come as a labyrinthine segment. Means then it will be having this horizontal segment, which is what, which is our tympanic segment, and followed by this tympanic membrane. Then it will be in vertical position. Vertical के साथ ये फिर उसके बाद stylomastoid foramen से बाहर आ जाएगा. Okay, so there are this few phases or few segments of this facial nerve. Okay, mainly what you need to know is that at which section or which part will give rise to this which branch. Okay, and based on this branch, we will tell what is the complication or at which level the facial nerve is got injured. For example, initially we know around this first genu, it will give rise to this nerve, which is known as what? Which is known as nerve to stapedius. Okay, and before this nerve to stapedius, around this first genu, means wherever it is taking turn, it is known as first genu. And around this first genu, it will give rise to this greater petrosal nerve. It will give rise to this greater petrosal nerve. And हमें पता है this greater petrosal nerve, it will go and supply this lacrimal gland. Or if there is any damage at this greater petrosal nerve or at around this first genu, then it will lead to this loss of lacrimation. Loss of lacrimation. Okay. Then after this first part, then it will be having this tympanic part. Here it will give rise to this. Before this second turn, it will give rise to this nerve to stapedius. Nerve to stapedius. So in the case of nerve to stapedius, क्या होगा? There will be the cause of hyperacusis. See, you are attending a marriage function. You know there will be this woofer side. There will be more noise will be there. And in such scenarios, you need to be protected from this noise-induced trauma. So in such cases, the stapedius will act and it will pull the stapedius, will pull the stapes bone from this window. So once it pulls, this sound won't be get transferred. So that is how this stapes works. So this, if there is a damage to the stapes, it leads to these features of hyperacusis. Fine. And then we studied in the taste sensations. There is this the normal sensations of the tongue. There can be this 5, 9, 10. Whereas this taste sensation will be carried from this anterior part by this facial nerve, which is known as coda tentonii. So this coda tentonii will be responsible for this taste sensations, and it will come out by this styloid process. Okay, after coming out to the styloid process, it will supply the muscles. Okay, it will supply this muscles of our facial expression, our smile muscles. So if there is any supply over here, this will result into this facial nerve palpus. So based on the locations, you can tell. So if there is any absence of lacrimation, then before genu there is a fracture, or before first genu there is a damage. And if there is any hyperacusis present or hyperacusis mentioned, then you tell there is this origin of nervous stapedius has been injured before the origin. Okay, remember. And if there is no taste sensations, then you will think this coda tympani is gone. So based on the history, you need to select the option like where it has been injured. Okay. Then about this few ear implants. If you see about this ear implants, this implant which is known as what? Or bone anchored hearing device. Bone anchored hearing device. See, initially what we can do is that we can give this type of usual hearing aid, but in some cases, like for example, if there is atresia of this EAC, if there is no formation of this EAC itself, then how the sound will travel? So in such cases, what we'll do, we'll insert this instrument into this bony part. So it is known as bone anchored hearing device. It is known as what? BAHA, not HAHA. Okay, it is what? It is the BAHA. Okay, it is what? It is the bone anchored hearing device. Fine. And next one, it is this cochlear implant. If you see this cochlear implant, you will able to see, you will pass this electrode into this inner ear, and there will be this receiver and there will be this transmitter. Okay, here outside there will be this transmitter and inside there will be this receiver. Okay, you will collect this sound and you will process it and you will set through this sender, and following this transmitter then you will receive inside. So this is what? This is this cochlear implant. Next one, if you see, sometime in a case of, for example, there will be the neuronal damage. For example, we will see in a case of schwannoma. For example, in a case of acoustic schwannoma, the nerve will be impaired, right? If there is no nerve itself, then how this impulses from this cochlea will be get transferred to there? So in such cases, we will go and implant directly into the brainstem. It is known as what? It is known as auditory brainstem. Yeah, correct. It is the auditory brainstem implant, which is known as what? 𝗵𝗶𝗶𝗵. Okay, it is what? If you see here, if you are able to see, there is this small electrodes. So it is this auditory brainstem implant. So, and this BAHA, as I told you, it is indicated in the case of anosmia or absence of this ear. Okay, and 𝗚𝚎𝑐 atresia, or because of some procedures or some things, 𝚎𝚎 becomes stenosis. Fine. And next one, if there is any chronic ear discharge, okay, we cannot keep the hearing aid, right? It will become wet and it will kharab ho jayega. So in such cases, we will use this bone anchored hearing device. Yeah, anosmia means absence of pinna. Fine. Next, we will move on to the nose part. In nose part, mostly they will ask you from the trauma perspective. Trauma mein kya puchenge? If you see, the most common bone to be fractured in the nose, kya? It is the most common bone which is fractured in the face, kya? It is nose. So nasal bone, it is the most common bone to be fractured. Okay, so if there is any nasal fracture, like this we see, right? अगर आप pillow रख के smothering कर रहे हो, तभी भी nose bone fracture होगा. So in such cases, first we need to see what are the types of fractures or what are the types of nasal bone fractures. ठीक है? अगर the fracture line is horizontal, okay? अगर fracture line is horizontal, अगर fracture line nose की horizontal पे चल रहा है, तो then it is what? Then it is the jagway fracture. Jagway fracture. Whereas if it is parallel, if it is parallel, then we'll call it as 𝗵𝗵𝗶𝗀 fracture. 𝗵𝗵𝗶𝗀. So here आप देख रहे हो, then there is this line is going fracture. Okay, this is the bone fracture, which is actually what? Which is this 𝗵𝗵𝗶𝗀 fracture. इतना याद रखो. And we know for reduction of this nasal bone fracture, what is the name of the instrument you will use? For nasal bone reduction, what is the name of the forceps you will use? Yeah guys, is it Ashley? No, it is what? It is the 𝗏𝗏𝗪's forceps. It is the 𝗏𝗏𝗪's forceps. Whereas for nasal septum, the nasal septal reduction, then we will use this Ashley's forceps. See, this W, it is looking like going inside. So we know outside it is a cartilaginous part, whereas inside it is the bony part. So अगर सीधा जाना है तो लंबा होना चाहिए, or it should be straight. So this 𝗏𝗏𝗪's forceps, it will be straight in nature. That's why we'll use this 𝗏𝗏𝗪's forceps. Right? Just remember. And for nasal septum, we'll use this Ashley's forceps. Okay? Then, yeah, I told you the most common bone to be fractured in nose, fractured in face, it is the nose. Okay? And उसके लिए हम क्या मैनेजमेंट करेंगे? In the case of nasal bone fracture, what we'll do immediate reduction, because once there is this formation of edema, it is difficult for us to reduce the bone. So we'll do with 𝗏𝗏𝗪's forces, but we'll do before the edema occurs. अगर edema आ गया, mostly within 8 hours, अगर edema आ गया, then we'll wait for 7 days, then reduce करेंगे. पहले edema को settle होने देंगे, then after that we'll do this reduction. Then we'll do this next part. For example, you are going to the mall and there is this automatic door, like it should open, but it is not open, so that you got hit into your nose. So initially what will happen is this septum will got injured, and we know the septum will be having these blood vessels. It leads to this collection of blood into this nasal septum. इसको हम क्या बोलेंगे? It is the septal hematoma, and the patient usually complains of there is a history of trauma and there is a difficulty in breathing, or there is a bilateral breathing difficulty. So ये क्या है? septal hematoma है. So in a case of nasal trauma which is causing the septal hematoma, then what you need to do? You need to do immediate aspirations. You need to do immediate aspiration of the blood, because if it is not being aspirated very much immediately, then this can lead to this formation of septal abscess. Agar septal abscess ban gaya, then it can lead to the septal perforation as well. It can lead to the septal perforation as well. ठीक है, इतना याद रखो. Next, we need to know about this paranasal sinuses and its visualization. हमें पता है there are this around this nasal cavity there will be this paranasal sinuses. ठीक है, there maxillary sinus है. Then we have our inside we have this ethmoidal and sphenoidal sinuses. ठीक है, then we have these frontal sinuses. ठीक है, and around this sinuses, what is the main important is that what is the views will you use? For example, there are 3 views you should remember of, or 2 views at least you should know. One is this Caldwell's view. If you see, the head is touching here and you are taking X-ray from here. So it is what? It is this Caldwell's view, which is this 𝗲𝗵𝗶𝗀𝗀 view. It is this 𝗲𝗵𝗶𝗀𝗀 view. It is this Caldwell's view. Yeah, it is the Caldwell's view. Caldwell's view. Next, there is one more view which is mostly we'll use to see this maxillary bone. Okay, to see this maxillary bone, हम क्या करेंगे? Maxillary sinuses. We'll use this one more view which is known as what? Which is known as here from mentum will pass the ray. So we'll do like this. So it is known as what? It is known as Waters view. ठीक है, तो Waters view में there are 2 views of Waters view. Waters view is usually what? It is the closed mouth view. See, closed mouth view. अगर means अगर आप means if you keep water inside the mouth, will you close the mouth or will you open the mouth? If you open the mouth, it will fall, right? So you will, in the case of Waters view, it is this closed mouth view which is used to see this maxillary sinus. Whereas we have one more view which is similar to this Waters view, but instead of closing the mouth, we'll keep it open. Okay, we'll keep it open. It is known as Pierce view. Okay, we will keep it open. It is known as Pierce view. So this is the Caldwell's view. Okay, Caldwell's view. We know this Caldwell's view which is mainly useful for this frontal sinuses and the ethmoidal sinuses. ठीक है, और sphenoid sinus देखने के लिए हम क्या करेंगे? We'll take from the lateral side. Okay, whereas for this maxillary sinus हम एक Waters view लेंगे, और हम मैंने बोला कि मतलब you should keep the water in, so you should close the mouth. ठीक है, whereas in the case of Pierce view, that is the open mouth plus Waters view. It is known as Pierce view. It is known as Pierce view. ठीक है, Pierce view. ठीक है, इतना याद रखना. And remember about this sinuses, there they will open. Means we know this nasolacrimal duct, it is usually opens into this inferior nasal meatus, because that's why if you start crying, okay, if you start crying, then you will get this water into your nose, right? You will have this nasal stuffiness. It is because of this internal, means because of this opening of this nasolacrimal duct at this inferior meatus. But we'll see in ophthalmology there is a condition where there is blockage of this duct. In those condition only will keep them to drain into medial meatus. Okay, अब के लिए just have a pause for it. Okay, then about this medial meatus you need to remember. See, in medial meatus M for M it will be having this maxillary sinus. फिर उसके बाद above this maxillary sinus we have this frontal sinus. We will have drainage from this frontal sinus. But the catch point is that which ethmoidal sinus will drain? Is it anterior ethmoidal sinus या posterior ethmoidal sinus? Remember, it is this anterior ethmoidal sinus. It is draining into this middle meatus. So like a family, it is draining. It is like a family. So frontal, anterior ethmoidal, and what? And maxillary sinus. All of the sinus, it will come and join here. Like mostly about this 𝗏𝗏 view, they won't ask, but 𝗏𝗏 view it is mostly used to see about this superior orbital features and things. Okay, just remember. Fine. And next about this special cells. Yeah, special cells. If you see, this is which sinus, guys? This is which sinus? Is it ethmoidal sinus? No, it is the maxillary sinus. It is the maxillary sinus. It is the maxillary sinus. And this is the orbit. This is the orbit. And we know in the case of orbit, if you see, there is a cell which is at the floor of orbit. The cell which is at the floor of orbit, okay? It is the Hallus cell. It is the Hallus cell. Agar if it is in this bulla, if it is on the middle meatus, it is what? It is the bulla ethmoidalis. It is the bulla ethmoidalis. Okay, ethmoidalis. Okay. Then, if you see, there is one more cell which is in relation to this optic nerve. Optic nerve के साथ in relation है. तो ये कौन सा है? It is the O for O. It is the onody cells. It is the onody cells. It is the onody cells. ठीक है? कितना याद रखो ये इसके बारे में. Then we'll come into some more parts of this trauma. If you see about this CSF part, this traumatic CSF rhinorrhea. We have this type of fracture which they are known as Leport fracture. In Leport fracture, the fracture type 1, it separates this palate. Okay, it will be fractured at the level of palate. Whereas in the case of Leport type 2, remember the hand 1, keep one hand, it is the Leport type 1. Whereas keep two hand, it is the Leport type 2. Leport type 2, it is what? It is triangular in fashion and it will cause damage to this cribriform plate. And if there is any damage to this cribriform plate, it leads to this leakage of the CSF along with this blood. It is known as traumatic CSF rhinorrhea. It is known as traumatic CSF rhinorrhea. Whereas type 3 Leport fracture, it is what? It is this craniofacial distension. It is the craniofacial distension. Okay, so it will be most commonly seen in the case of type 2 and type 3. Type 2 and type 3 Lefort's fracture. Okay, type 2 and type 3 Lefort's fracture. Okay, and in such cases, you will be able to see this type of halo. And this is what? This is in the case of traumatic CSF rhinorrhea. So, what is the confirmation test or what is the gold standard test you will do here? You will do the confirmatory test, which is what? This is this beta-2 transferrin analysis. This is beta-2 transferrin analysis. And we studied yesterday where you will see this beta-2 microglobulin deposition in which type of amyloidosis or in which condition? Remember, this beta-2 microglobulin will be seen in a case of dialysis. Okay, remember, it is seen in a case of dialysis. Okay, and mostly how will you differentiate this CSF rhinorrhea with other secretions? You see, the CSF rhinorrhea, it won't be stiff backs. Means when you do like this, you won't sniff this thing back. And when you keep a kerchief, you will be able to see this halo sign. Halo sign or target sign. Fine, and the patients cannot sniff backs, and it will be non-sticky, like our nasal secretions, it will be sticky, right? Whereas this is non-sticky in nature, fine. And yeah, and to confirm, we'll use this beta-2 transferrin in nature. Yeah, it will be clearly fluid, but in a case of trauma, it may mix with blood. Okay. Then for radiologically, what we can do is that we can do this 𝗧𝗵𝗶𝗀 of skull, and we can do this T2 weighted MRI imaging. You know, water is white, so whatever CSF it's leaking, it can come in MRI T2 weighted imaging. Okay, and we can do CT cysternography, but we need to put dye into the subarachnoid space, so it is much invasive. Okay, and or else we can do nasal endoscopy with intrathecal fluorescent dye. Means we need to inject dye here and we need to do this nasal endoscopy. Okay, that is very difficult. Okay, so the most of the treatment, it is what? It is this conservative management. It is the conservative management. Then about this epistaxis. Once you see about this epistaxis, we know that mostly the patients will be having these complaints. They will be scratching their nose, and because of that there will be a bleeding. Okay, and we know the most common cause of epistaxis location, it is this Little's area. It is the Little's area, and Little's area, it locates at this anterior-inferior part of this nasal septum. Anterior-inferior part of this nasal septum. Okay, and previously, and this will form a plexus which is known as what? Kezzelback's plexus. It is known as what? It is known as Kezzelback plexus. And this Kezzelback plexus will be having this supply from this greater palatine artery, palatine artery, which is the artery of epistaxis. Artery of epistaxis. Okay, and then superior labial artery and anterior ethmoidal artery. There are few evidences which tell there is involvement of posterior ethmoidal artery in the Kezzelback's plexus as well, but as of now we consider it as anterior ethmoidal only. So, okay, just remember, it is not a still not a part of Kezzelback plexus like that you consider. But now in recent editions they start using it. So see, what are this Kezzelback's plexus? It will be formed by this anterior ethmoidal artery, yeah, but not posterior ethmoidal artery. No, if they ask you in exam, which of the following is not a part of Kezzelback's plexus? If you have all these options, you choose posterior ethmoidal artery. Okay, and it is still controversial. Okay, see, it is what it is, this anterior ethmoidal artery and transfacial artery, which is this supralabial artery, and palatine artery. See, here this palatine artery and this greater palatine artery, palatine artery and greater palatine artery. So all of these arteries will give rise to this formation of Kezzelback's plexus. Okay, Kezzelback's plexus. Now what they will ask you, if a patient of epistaxis come to you, what is the first thing you will do? What the first thing you will do? You will tell them to do this tortoise method. What you will tell? You will tell them to pinch the nose. You will tell them to pinch the nose and to sit and bend your neck and sit behind. You will pinch your nose and you will bend your neck and you will sit like this for a while. And if it is not being controlled by this, then we'll do nasal packing. In nasal packing means we'll put up this glass piece inside the nose, because we know this mostly this anterior Kezzelback's plexus which is bleeding. So in such scenario, we'll do this nasal packing with saline and adrenaline. It will cause vasoconstriction, and because of this compression force, the bleeding will stop. But if it doesn't stop, then we'll move ahead with posterior nasal packing. Anterior, then posterior nasal packing. Yeah, good. Then we'll do a thing which is known as what? If both of them they didn't stop it, we know the artery of epistaxis, it is the what? It is the sphenopalatine artery. So next step what we'll do is this, we'll do go by endoscopic, and we'll do endoscopic sphenopalatine artery ligation. Endoscopic sphenopalatine artery ligation. Okay, and if it doesn't resolve, then we'll go for the next method. Okay, next method. What is that? Because we know all of them, they are the part of this facial artery, and before this, the sphenopalatine artery, this is the branch of maxillary artery. So we'll ligate the maxillary artery first, and if it doesn't stop, then we'll go on ligate the axial carotid artery. Okay, we'll go on ligate the axial carotid artery. So first we'll ligate this SPAL, this endoscopic sphenopalatine artery ligation, followed by this axial carotid artery ligation, and if nothing stops, if still the bleeding happens, then we need to go on ligate this anterior ethmoidal artery. We'll go on ligate this anterior ethmoidal artery. Bas itna yaad rakho. So anterior nasal. So first we'll pinch the nose. Then what we'll do? We'll do anterior nasal packing, posterior nasal packing. Then we'll go on ligate this sphenopalatine artery. Then we'll go on ligate this maxillary artery. Then we'll go on ligate this external carotid artery. Then we'll go on ligate this anterior ethmoidal artery. Bas itna yaad rakho. Fine. Then we'll move on to the next condition. Next, there will be usually a female who is presenting with features of wide roomy nasal cavity. Wide roomy nasal cavity, and there is a formation of this excessive crust. So there is this wide roomy nasal cavity along with this formation of this excessive nasal crust. This will be typically seen in a case of females, okay, females, and this is seen in a case of atrophic rhinitis, also known as Oziana. The causative agent of this, it is what it is, this Klebsiella ozianae, okay, Klebsiella ozianae. On examination, if you are able to see this atrophy of this turbinates, this inferior turbinates, all these turbinates will become atrophied and shrunken, and along with this there is this crust formation. And when you sit and examine the patient, you will be able to see there is a presence of this foul smell. Okay, there is a smell, but the patient does not feel the smell because of this olfactory involvement. So they will be having this type of anosmia, which is known as merciful anosmia, which is known as merciful anosmia. Okay, merciful anosmia. So हम initially treatment के लिए क्या देंगे? So the things is that this, they are wide roomy nasal cavity, they causing this dryness, causing this excessive crust formation, and this turbinates they are hypertrophied. तो उनको हमें energy भी देना है और ये crust को lysis करके बाहर भी ले आना है. Then we need to do two things. We need to supplement with this estrogens, vitamins. Then along with this we'll give sodium biborate, bicarbonate, and sodium chloride. Okay, to support and to remove the crust. If this doesn't help them, then we'll do this surgery, which is known as modified Young's operation. Because of this more air going, this causing this dryness. Okay, because of this air, there is a dryness. So if you close this nasal cavity and left over this small opening, this leads to this condition, which to heal this condition. So this is known as what? This is known as modified Young's operation. This is known as modified Young's operation. This is the partial closure of both nostrils. Okay, partial closure of the both nostrils. दोनों को completely बंद नहीं करना. अगर complete बंद करना, like if we completely make them close, then ऊपर चला जाएगा. So we need to close them partially. We need to close them partially. Fine. Then we'll move on to the next part, which is this nasal polyps. Okay, there is this patient who is complaining of this kind of nasal fullness, and mostly they are this allergic patients who is having this nasal fullness. So mostly on examinations, you can do two examinations. Okay, there are two types of polyps. One is known as anterocoinal polyp, another one is known as ethmoidal polyp. Yeah, Dr.G, it is in the ratio of 2:1:1. Oh, correct. Yeah, if you see this nasal polyp, then it is what it is. These two types. One is known as what? One is known as this anterocoinal polyp, and another one is known as what? Ethmoidal polyp. So remember, it is anterocoinal. Remember this coina. It is at the posterior aspect of the nose. So this anterocoinal polyp, it will be at the level of posterior part of this nose. So it is at the posterior part of the nose. So will be visible in a case of posterior rhinoscopy. It will be visible in a case of posterior rhinoscopy. And we know this polyp, it is what? It is this prolapsed mucosa. It is this prolapsed mucosa of this sinus. So because it is a prolapsed mucosa, it will be avascular. So it will be pale in color. It will be having this. It won't be having what? It won't be having the blood or this very pinkish color. it will be pale in appearance, okay, and it will be a result of this chronic sinusitis, okay, and in anterocoinal polyp it will be single, okay, mostly it will be single in nature, whereas this ethmoidal polyp it will be mostly in anterior and it will be like a bulky, so it will be multiple and seen on anterior rhinoscopy, anterior rhinoscopy. So it is what it is, this ethmoidal polyp, it is this ethmoidal, whereas posteriorly we see it is the posteriorly we'll see the anterocoinal polyp. Okay, बस इतना याद रखना. Okay, these are the things you need to remember about this polyps. Okay, फिर आगे बढ़ते. Next, you say this adolescent male, like young male or adolescent around 18 years male, who is presenting with features of painless bleeding and this kind of nasal mass and this kind of deformity which is causing this involving into the eye as well, known as frog face deformity. So what is the condition, guys? In which conditions there will be presence of this painless nasal mass along with this painless nasal bleeding along with these features of this frog face deformity? Yeah, guys, that is what it is, this juvenile nasopharyngeal angiofibroma. So there will be this 12 to 16-year-old boy with the features of nasal mass and profuse epistaxis, presenting with features of also nasal obstruction and cheek swelling. Okay, and if there is any involvement of this orbit, it lead to this sign which is known as what? Frog face sign. Next on CECT, if you are able to see, this is the maxilla. And maxilla there are two walls. This is the anterior wall and this is the posterior wall. Okay, so this is the bowing of this posterior wall. It is not anterior wall, it is the bowing of this posterior wall of this maxilla. Okay, and this is known as Høllmann-Müller sign. It is known as what? It is known as Høllmann-Müller sign. It is known as Høllmann-Müller sign. And the treatment of choice, it is the surgery. And treatment of choice, it is the surgery one. Fine. And next, we'll move on to this pharyngeal abscess. 𝗶𝗵𝗀, it is nothing but it is just the formation of abscess in the tonsil. Take a formation of abscess in the tonsil. And we know if there is an abscess formation, this abscess, what will happen? It will form here and it will cause pushing this uvula. So this formed abscess will push the uvula to the opposite side. So if it is like this, we will call them as 𝗶𝗵𝗀. And because of this, the patients will be having a hot potato voice. Okay, we'll be having this hot potato voice. Yeah. Here also in a case of juvenile nasopharyngeal angiofibroma, we won't do biopsy. Biopsy is contraindicated. Okay. And this is how 𝗶𝗵𝗀. This is what? This is the 𝗶𝗶𝗀. Okay. There is a patient with features of fever, dysphagia, throat pain, difficulty in mouth opening and hot potato voice. Okay. This is suggestive of 𝗶𝗶𝗀. Okay. It is suggestive of 𝗶𝗶𝗀, are also known as peritonsillar abscess. Peritonsillar abscess. So it is what is that? Due to collection of pus between this tonsil and its bed. And an examination you will be able to see. This tonsil is pushing this uvula to the opposite side. Okay, and now you saw a patient. There is the presence of this abscess. Okay, but the uvula is in center. But he is also presenting with features of outer neck swelling. So under bhi abscess hai or bahar bhi abscess hai. So if it's inside also, outside also, it is what it is, this parapharyngeal abscess. It is what it is, the parapharyngeal abscess. And if you see just swelling and abscess over submandibular region. So ये क्या हो सकता है? It is what it is, this Ludwig's angina. Ludwig's angina. It is a Ludwig's angina. ठीक है, याद रखो. It is a Ludwig's angina. ठीक है. Next about this adenoids. Okay. If we see about this adenoids, we already saw. We saw this adenoids, the child will be having these features of recurrent fever, there is a blockage of the nose and there will be features and there will be this peculiar facial features which include this overcrowding of the teeth and there will be this high arched palate and there will be this mouth breathing. Okay, because adenoid it will be from this nose connection to this nose to the mouth, right? So they will be having this difficulty in breathing by nose. So they will be having this mouth breathing. So there is this features of recurrent respiratory infections along with the features of mouth breathing, okay, along with the features of mouth breathing and crowding of this upper teeth, okay, crowding, there will be this crowding of this upper teeth and because of this there will be a blockage of this nasal cavity which is known as rhinolalia clausa. Because of this rhinolalia clausa there will be hyponasality, okay, there will be this hyponasal voice, it is known as hyponasal voice, okay. So So for this adenodectomy, to remove, we'll do this surgery. Okay. To surgery, we'll pose them in a position which is known as rose position, means we'll extend them. Okay. We'll extend around this, the junction of this cervicothoracic junction, and we'll extend to see the field. Next, how will you do? We'll do either coagulation or suction diathermy. We'll do the surgery. And in some conditions, if you do overflexion, will cause what? Overflexion or overextension will cause this dislocation of atlas, dislocation of the atlas axis. It is known as what? It is known as Grisel syndrome. It is known as Grisel syndrome. Fine. Then this is the adenodectomy. Then in the case of recurrent tonsillitis, then we need to remove the tonsils as well, right? So in such conditions, it can lead to some complications. The complications of this tonsillectomy include, the one of the main, it is what it is, this hemorrhage. Yeah, it is the C1 to C2 subluxation. Fine. And this tonsillectomy, it leads to few of these following complications. The complications include mainly the hemorrhage. The primary hemorrhage, it occurs during the surgery. So during surgery, whatever hemorrhage you can conclude by cauterizations. Whereas this reactionary hemorrhage, it occurs within 24 hours, mostly in ward. Okay, the patient is admitted in ward, as in a post-op ward, and the bleeding starts. Okay, now it is because of the slippage of the ligature. You put a ligature and it is being slipped off. Okay, there is a slippage of this ligature. So because of the slippage of this ligature, this will cause this bleeding. And in such scenarios, you need to shift them to OT, and you need to resuture it back. Remember. And about this secondary hemorrhage, it happens mostly after the 5th day of surgery because of this infection. It's actually after 24 hours. It is usually happening after 24 hours. Okay. So it will be usually because of these infections. And we know if there is any presence of infection, then we need to give antibiotics. So in the case of infections, we give antibiotics. We'll give antibiotics. And next one is the nasopharyngeal carcinoma. Okay. अगर आप nasopharyngeal carcinoma के बारे में सुनेंगे, then the most common sign the patient will present with what? It will be having this cervical lymphadenopathy. Will be what? Will be this cervical lymphadenopathy. So there will be this features of painless cervical lymphadenopathy in the old age patients, and along with this nasal bleeding episode. And we know, we already studied, if Epstein-Barr virus is in close relationship with this nasopharyngeal carcinoma. So there is a 56-year-old male who is complaining of nasal bleeding. Under examination, we will be able to see there is this painless cervical lymphadenopathy. और हमें पता है this nasopharyngeal carcinoma, it is origin from this fossa of Rosenmuller. Okay, this is this eustachian tubal opening, and this is the fossa of Rosenmuller, where this tumor of esopharynx which is occurring. So fine. So this is the first one. It is the eustachian tubal opening. If you see, most anteriorly it is the eustachian tubal opening, and posteriorly, you see, or from you like this. This hand, this is the eustachian tubal opening, and this hand, this is this fossa of Rosenmuller. Okay. So this is like this. So actually it is oriented like this. So this is the first, you will see this eustachian tubal opening, followed by this, you will see this fossa of Rosenmuller. You will see this fossa of Rosenmuller, and it can lead to this triad which is known as Protas triad, which can be removed by this mnemonic as NPC. So initially there will be this neuralgia, and neuralgia, it is due to the involvement of 5th nerve. It is due to the involvement of 5th nerve, and there is this palatal palsy, ipsilateral palatal palsy, due to the involvement of this 10th cranial nerve, and there also will be this ipsilateral conductive hearing loss. There will be a conductive hearing loss, palatal palsy due to the involvement of 10th nerve, and there is a involvement of this neuralgia due to the involvement of this 5th cranial nerve. So NPC, neuralgia, palatal palsy, and conductive hearing loss. Neuralgia, palatal palsy, and conductive hearing loss. We studied in CSOM, there is a Grady-Negro syndrome, GERD. Grady-Negro syndrome, E for ear discharge, R for what? What is the R one? It is what? It is this retroorbital pain. Retroorbital pain. Here also it is due to this 5th nerve involvement. Okay. Whereas here also there is a neuralgia which is due to the 5th nerve involvement. And here the third D for this diplopia due to this 6th nerve involvement. Okay. 6th nerve involvement. Okay. This is about this nasopharyngeal carcinoma. So to treat this, what we'll do? We'll do this chemoradiation. But yeah, we'll move on to the next part where there is this laryngomalacia. Usually this laryngomalacia, it is an means floppy epiglottis, and it is a congenital condition, and mostly it won't have any complication or any symptoms until unless there any complications arises. Mostly the stridor will be there in supine position. So when you turn the baby into prone position, the stridor will settle. Okay, the stridor will settle. Okay, in supination, in supine position, the baby will be having the stridor, whereas you up ulta karogi means you make them in prone position, then the stridor will decrease. Okay, and we know it is mostly asymptomatic in nature, and here you will be able to see this type of omega shaped epiglottis. Okay, omega shaped epiglottis are either cry be normal रहेगा. Unlike esophageal herpes, there will be abnormal cry. Here the cry will be normal. And the treatment what will do? It is the mostly the conservative management it will do in a case of laryngomalacia. Okay. Next one about this epiglottitis and tracheobronchitis. So if you see about this epiglottitis it is the involvement and the involvement and this inflammation of this epiglottis. We know this epiglottis, it is in close relations with this tongue. So if there is an inflammation of this epiglottis, then it will go and irritate the tongue. Means here is the tongue, here is the epiglottis. It will go and irritate the tongue. When it starts irritating the tongue, the child will not swallow the saliva. So there will be drooling of saliva. Okay, there will be drooling of saliva. The child will be having this difficulty in swallowing, in breathing, and everything. Okay, so this is the typical feature of this epiglottis. There is a 5-year-old child with a fever, inspiratory stridor, and there will be a drooling of saliva. And then, okay, it is what it is this thumb sign where you will see in a case of lateral side of this soft tissue neck. Next, you will see what is the management you will do. Once the baby comes, the baby is unable to even breathe, I told you, right? So immediately what you will do? You will do immediate intubation. So you will secure the airway, and you will avoid multiple laryngoscopic procedures. Because multiple karoge to it will cause more spreading and more injury to the area. So you will avoid multiple laryngoscopic procedures, so that initially itself we will do intubation. Okay, and for treatment you will give dexamethasone and antibiotics. And the most common cause now it is what is Streptococcus pneumoniae. And if they mention in questions, there is an unvaccinated child. Who is presenting with this features of this epiglottitis. What is there? What is the causative agents? Then you can think of 𝗵𝗵𝗶𝘀 influenza. Then we will see about this acute laryngotracheal bronchitis. In the case of acute laryngotracheal bronchitis, the causative organism is it is this parainfluenza virus. And we know this acute laryngotracheal bronchitis, this parainfluenza virus, it affects the trachea. So it will produce this, and AP X-ray will produce, see this steeple cell. You will see this steeple cell. So on X-ray you will see this steeple cell. There will be this 3-year-old child will be complaining of low fever, mild respiratory difficult, and this cough resembling this boggling of this dog, which is known as what? Whooping cough. Will be seen in a case of acute laryngotracheal bronchitis, also known as croup. Okay, and this here the treatment will be providing this humidified oxygen and adrenaline and dexamethasone. As it is viral infections, mostly will avoid antibiotics until and unless there is a secondary infection or secondary complications. Right? And next, you saw a child who is presenting with this hoarseness of speaking. This child will be having this hoarseness of speaking or hoarseness of voice. You will be able to see, you plan to do an laryngoscopy, and on laryngoscopy you will be able to see this multiple outpouching structures. So, it is the juvenile laryngeal papillomatosis. Okay, and the causative agent is that is this HPV6 and 11. HPV6 and 11 for treatment you will do MLS, microlaryngeal surgery with carbon dioxide laser. Whereas if you see, there is adult smoker. Instead of this multiple outpouching, with the vocal cord is like a single outpouching. Okay, single flocculent swelling in a smoker, adult smoker. तो आप क्या think कर सकते हो with the features of this dysphonia and diplophonia. या ये कौन सा ये क्या हो सकता है? There is this single flocculent swelling. ठीक है? There is a collection of fluid in between these layers of vocal cord. ये क्या हो सकता है? It is what is the 𝗵𝗵𝗀𝗃𝗃 edema. It is the 𝗵𝗵𝗃𝗃𝗃 edema. Remember, it is the 𝗵𝗵𝗃𝗃 edema. फिर उसके बाद आगे बढ़ते. Next, this vocal nodules. This vocal nodule, it is most commonly seen in a case of this professions where there is the loud using of this shouting or loud voices. Like they are known as singers, screamers, and teachers nodules, where there is a history of vocal abuse is there. Okay, prominent vocal abusers. Okay, and their complaints is the hoarseness of voice. And on examinations, you will be able to see it is the bilateral, bilaterally located at the level of junction of 1/3 to this anterior 1/3 to this posterior 2/3. You will be able to see there is this bilateral small nodule. They are known as vocal nodule, or also known as teacher's nodule, also known as singer's nodule. तो इनके लिए क्या करेंगे? सुनो, अब थोड़ा देर के लिए रुको. Means you just wait for a while. Don't speak loudly. Speak less for few days. So this is known as what? This is known as speech therapy. So we'll give speech therapy. Sometimes this can be occur because of this facet reflex. तो हम दो चीज करेंगे. एक चीज क्या है? First we'll do speech therapy, which is just to give some voice rest. Then we'll give them proton pump inhibitors. तो यही करेंगे in a case of vocal nodules. And in a case of vocal nodule, it is seen in a case of sudden vocal abuses. Means normally, means you are hearing a DJ in a party, okay, or you are dancing in the pub, and then you saw this sudden your favorite song, okay, favorite song sung by 𝗵𝗵𝗶𝘀 Puja. Then you started hailing, okay. There is a sudden vocal abuse, okay. There is a sudden vocal abuse leading to this one polyp formation, and it is also around the location of anterior 1/3 to the posterior 2/3, anterior 1/3 to this posterior 2/3, okay. So it is what it is, this vocal polyp, okay. It is the vocal polyp, it is the vocal polyp, you will see here, okay. Yeah, and it will be mostly unilateral in nature. It will be mostly unilateral in nature, and there will be complaints of dysphonia. There will be complaints of dysphonia. To treat this, you will use this microlaryngeal surgery. You will do what? You will do this microlaryngeal surgery. Okay. Then after laryngectomy, आपने तो उड़ा दिया. Means you just took this larynx, just removed it because of there is any laryngeal cancer. So in such conditions, हमें तो उनको means we need to make them respire, and also we need to make them to speak a little, right? So in such cases, we can do different types. One is what? We'll tell them to take the ear and we'll speak from the esophagus. Okay, that is known as esophageal speech. There is some more devices which we can use, like this one, which is known as Bloom-Singer's prosthesis. Bloom-Singer's prosthesis, yeah, prosthesis, yeah. Okay, so if you are able to see, this is known as what? This is known as Bloom-Singer prosthesis. Okay, fine. Okay, next one, it is this electrolarynx. Okay, it produces this robot like a voice. So Bloom-Singer prosthesis and then the electrolarynx. These are the few processes we will use for this post laryngectomy voice rehabilitation. Fine. And there will be a few cases. There is usually these diabetic patients or any immunocompromised patients who is on long-term steroid therapy. Now they are complaining of this blackish discoloration of this nose, or this around the nose there is a mass which is in blackish color or necrotic mass. What you will think of? What you will think of? Best. Okay, it is the mucormycosis, because it is the mucormycosis. Okay, so this is what? This is the mucormycosis. Okay, and in a case of mucormycosis, it can even involve into the eye. So eye के around भी ये क्या हो सकता है? It can come and involve around this eye and can cause diplophoria. So there will be swelling around this eye, redness and swelling around the cheek. So for this diagnosis, what we'll do? We'll do this MRI with contrast. We'll do this MRI along with this contrast. Okay, and treatment हम क्या करेंगे? We'll give this amphotericin B. We'll give this amphotericin B. Okay. Then we need to see about the structures. The first structure, it is what? It is this. Mark this 4. मैंने बोला क्या पहले क्या आएगा? It is the eustachian tube opening. And the second, it is the fossa of Rosenmuller. Okay, fossa of Rosenmuller. That is the eustachian tubal opening, and next one, it is the fossa of Rosenmuller. Okay. Then we'll have one more syndrome which is known as Ramsay-Hunt syndrome. Okay. It is nothing but our facial nerve palsy. If it occurs because of this herpes zoster, we'll call them as Ramsay-Hunt syndrome. Okay, Ramsay-Hunt syndrome. और हमें पता है इस facial nerve palsy, okay, if it is involving this lower motor neuron, okay, then it will be involving this lower motor neuron. It will be involving the same side, same half will be involved, and we know there will be this what? There will be non-closing of, there is no complete closing of eye, and then there will be what? There will be loss of this nasolabial fold, and there will be absence of wrinkles, and along with this, the corner of the mouth will be shifted to the opposite side. There will be this corner of this mouth deviation to opposite side. Yeah, this is due to the facial nerve involvement, And for these cases, we'll give two things. Okay, if it is because of trauma, we'll give steroids to decrease the inflammation, or if it is because of this infections like herpes zoster, then we'll use acyclovir. Or mostly we'll don't differentiate them, so we'll give them both acyclovir and steroid therapy in a combination. Okay, this is the lower motor. Whereas upper motor, it is this contralateral opposite side, just lower heart. Just opposite side lower heart will be involved in the case of upper motor neuron. It will be the contralateral lower half only, lower half. Okay, remember. These are the things you need to remember about this Ramsay-Hunt syndrome. Then uske baad they ask the simple questions. What is this bone? This you know, it is the stapes. Tell me, what is this bone? Is it malleus or incus? Like I said, is it malleus or incus? The second bone? Second bone, ye kya? Second bone, it's what? It is the malleus. It is the malleus. Whereas the third one, kya? No, that is what? That is where the confusion. So remember, with these small things we make mistakes. अगर आप स्मॉल थिंग में भी मिस्टेक करोगे ना, आप मेन एग्जाम में जाके यही मिस्टेक करोगे. तो ट्राई टू डिफरेंशिएट. अगर उसका ब्रॉड है तो इट इज व्हाट इट इज द इनकस. इनकस इज अ ब्रॉड इन नेचर. ठीक है. एंड वी हैव फ्यू मोर प्रोसेसेस. दे आर नोन एज टॉर्प and PORP. Partial prosthesis, like for example, the half of the bones, they are still intact. So we'll call them as PORP. Whereas the entire ossicular chain is replaced, we'll call them as TORP. Total ossicular reconstruction prosthesis. So this is a TORP, and whereas these are the PORP one. Okay, these are the PORP one. So remember, it is a partial one, and whereas this one is total ossicular reconstruction prosthesis. Okay, and as I told you, you saw a patient who is presenting with features of sensory neural hearing loss. Okay, and you did a gadolinium enhanced MRI. Okay, nothing but a contrast enhanced MRI. And contrast enhanced MRI, you will be able to see this bilateral ice cream cone appearance. This bilateral ice cream cone appearance in a case of contrast enhanced MRI will be seen in a case of, it will be seen in a case of acoustic schwannoma, also known as vestibular schwannoma. Okay, remember, it is seen in a case of vestibular schwannoma. And we know in the case of vestibular schwannoma, if it is occurring in bilaterally, it is because of this NF2. So this, if it occurs on the two sides, it is what? It is because of this NF2. So this is the vestibular schwannoma. Mostly it will originate from this inferior vestibular nerve. It will be originating from this inferior vestibular nerve. So these are the main things and most important topics you need to remember from this ENT perspective. Just remember one thing, it is not everything what you read, okay, like what you read or what you do, it is a little thing, it will be in your conscious mind, whereas rest of the things, it will be behind you. It means it is under your subconscious power, like something you read like 1 year before or few months before, but see, this whatever you read, it will go and sit into your subconscious mind. Okay, that will provide you this infinite power to solve this examination, to pass this examination. Okay, okay guys, that's it about this ENT part.